I'm Linda Martin, and I'm co-director of Mission Cure, and I'm here with Megan Golden, who is also Mission Cure's co-director and co-founder. And today's webinar is on total pancreatectomy and islet auto-transplantation, or TPIAT, and is focused on a topic we know patients have many questions about. We're honored to be here with Dr. Melena Bellin of the University of Minnesota, who will give us the latest information on the surgical intervention for severe pancreatitis. And as I was starting to say, just a few housekeeping items before we start. Our webinar will be recorded. Today's webinar is listen only, but we definitely want to hear from you. Our presenters will address questions at the end of the webinar, but feel free to submit your questions anytime. Just type in your question and click send. You can also use the Q&A box to let us know if you're having any technical problems, although obviously I was having my own technical problems, but we'll try to solve those if anyone else has any coming up. The webinar recording will be posted on the Mission Cure website, YouTube channel, and Facebook page within a day or two. And please help us spread this valuable information and share the webinar with anyone who couldn't make it today. So let's get started with today's agenda. First, I will give a brief overview of Mission Cure. Then Dr. Bellin will tell us about TPIAT, how this procedure evolved over the past 40 years, the details about the surgery itself, as well as the things you should know if or when you're considering if TPIAT might be right for you or a loved one. Following Dr. Bellin's talk, we will hear from Amy Jensen, a patient who had TPIAT just about 8 weeks ago. Amy will talk about how and why she decided to go forward with TPIAT and her experiences before, during, and after her surgery. And after that, we will have plenty of time for your questions. Mission Cure was founded in late 2017 by Megan and her brother Eric. Prior to founding Mission Cure, Megan was working for a nonprofit that uses innovative funding mechanisms to increase funding for early childhood programs. During this time, Eric had been diagnosed with chronic pancreatitis, and as Megan and Eric searched unsuccessfully for a treatment to relieve his pain, they realized that a similar type of innovative financing could be applied to cure chronic pancreatitis, and Mission Cure was born. I joined the organization shortly thereafter when I was helping my daughter search for information and solutions for her unrelenting pain. For the past year, Megan and I and our small but mighty team have engaged with well over 1,000 patients and families, researchers, clinicians, government officials, industry representatives, and others to finally bring together the best minds to problem solve, find solutions that meet the needs of patients, and for pancreatitis. We have been getting tremendous support from the whole scientific community as we work toward a cure. We work closely with the National Pancreas Foundation and others, and we are especially grateful to the AbbVie Foundation, which provided the funding to make this webinar series possible. Now, about our first year of operation, it's been a very busy one as we've laid groundwork and actively brainstormed, collaborated, and partnered with stakeholders throughout the pancreatic community. This slide shows just a few of the areas we worked on last year. In the interest of time, I'm not going to go into depth on these today, as most were covered in our last webinar. So if you missed it, it's still available on our website. But just a few highlights from 2018. As you know, we launched our patient and family webinar series, of which this webinar is the fourth. Our first webinar was on pediatric pancreatitis. The second was on genetics and pancreatitis. The third, just a few weeks ago, on Mission Cure's strategy to find a cure. These are all available on demand on our website if you missed any of them. Last year, we spent a lot of time defining and refining our cure strategy, which is our approach to efficiently driving research and development to build a portfolio of promising therapies that will lead to effective treatments, prevention, and even a cure for chronic pancreatitis within 10 years. We even made our first investment in a research project that will give us key information to help expedite other research projects in the coming year. In 2019, we will really start to implement our cure strategy by investing in research projects and new therapies recruit impact investors, and develop our financing model and grow our engagement with patients. So stay tuned. Big things are coming. Now, I'm delighted to introduce our presenters for today's webinar, Dr. Melena Bellin and Amy Jensen. Dr. Bellin is a leading expert on islet cell transplant for those who have type 1 diabetes and for those who have had their pancreas removed to treat chronic pancreatic disease. Dr. Bellin is an associate professor and endocrinologist at the University of Minnesota and a key member of the TPIAT team. Dr. Bellin has published extensively on TPIAT, on islet transplantation, and advances in diabetes research, and is a frequent presenter at medical conferences worldwide. And now I'll turn it over to Dr. Bellin.
Thank you. Thank you, Linda and Megan, and to Mission Cure for hosting this webinar today and giving me the opportunity to present. I am an endocrinologist, so I'm going to give you the medical perspective on TPIAT. So I'll talk a little bit about the surgery, of course, but know that I'm not a surgeon and they're performing the procedure. I realize people on this call are probably coming from all different angles and different history. Some of you may have had the TPIAT or be very close to having TPIAT and may know quite a bit about it. But for some of you, this might be all new. So just start really simple with the acronym. When I say TPIAT, what that stands for is total pancreatectomy with islet auto-transplant. So basically this surgery is primarily for people who have pancreatitis, either recurrent acute or chronic pancreatitis, and they're having their entire pancreas removed. So it's a total pancreatectomy piece. And the islets are isolated from the pancreas and placed back into the liver, which is the islet auto-transplant. So I'll get into the surgical details a little bit more, but just so you have the basic context of what I'll be talking about. Talk about the history of TPIAT and how that's evolved, and why we consider doing TPIAT, and particularly for what patients or for who do we consider TPIAT. And many, many people ask, when is the right time to intervene? I have chronic pancreatitis. When is that right time to do TPIAT? And I don't have a perfect answer for everyone, but we'll talk about some of the factors that go into that decision and what the surgery involves. And then finally, we'll wrap up with what to expect after TPIAT, and that includes what to expect from the recovery process, from the pain recovery and pain outcomes and the diabetes portion, and other general health issues that we need to consider around the TPIAT surgery. So first, just briefly to talk about the history of TPIAT, it actually isn't a particularly new procedure. The first TPIAT was done by David Sutherland and Dr. Dejarian, who were transplant surgeons at the University of Minnesota interested in pancreas and islets back in 1977. However, it was used relatively sparingly in very severe cases of pancreatitis for many years. So although it's been around for about 40 years, it's really gained more traction in the past 10 to 20 years. You can advance the graphic here. So there's a growing number of procedures and a growing number of centers who are performing this procedure. Currently in the US, there are probably approximately 15 centers that are actively performing the procedure within the past year or so. And 23 to date since 1999. But overall, this is still a relatively uncommon procedure, so it's hard to get the exact numbers, but if we look at the medical literature and the Collaborative Islet Transplant Registry, we would estimate that there are approximately 1,500 procedures that have been done to date. So it certainly isn't by any means the first step in chronic pancreatitis, but it is a procedure that's becoming increasingly recognized for difficult cases of disease. So very briefly, these are the centers that have reported being active in the most recent year or so in TPIAT. I'll say there are some centers that have been historically active who maybe haven't done as much in the past few years, and some newer centers that are getting up and running. So this may not be an all-complete list, but it is a map for your reference. So just to start very basically, who do we see for consideration of TPIAT? And it's obviously patients who have pancreatitis, and they primarily present with pain. So I'm sure this is very familiar to people on the call, but pancreatitis is a very painful disease. And there are multiple reasons why people with either acute, recurrent acute or chronic pancreatitis may get pain. You can get strictures or stones in the pancreatic ducts that obstruct the duct and cause intraductal pressure and pain. pain, you can get inflammation and ischemia, anatomic changes like pseudocyst, and inflammation, including inflammation around the nerves of the pancreas. And all of that is a very a painful condition, but there's various reasons why someone might actually have pancreatitis. And we see patients who come for surgery with various inciting risk factors for the pancreatitis. We are seeing more and more patients who come to us with hereditary or genetic risk factors for pancreatitis and consider TPI T. Those are primarily problems in the trypsin gene pathway. So the enzyme in the pancreas, trypsin, is inappropriately activated in the pancreas and causes inflammation, or a problem with the pancreatic ductal bicarb secretion with the CFTR gene. But we also see patients who have non-genetic causes of disease. In fact, very often we see adults who have what we would call idiopathic disease, or we're not real sure why they got pancreatitis in the first place, or they may have anatomic obstruction like pancreas divisum, or sometimes a medication or toxic exposure like alcohol exposure that incited the process. You can advance to the next slide. So obviously surgical therapy is not our first step in treating pancreatitis. So the first step is really doing medical therapy. Now, of course, medical therapy is somewhat limited, but that includes supportive therapy for flares, a pain management program, sometimes pancreatic enzymes or antioxidant therapy is considered. And for some patients, particularly if they have problems with the pancreatic duct, like a stricture or a stone, endoscopic therapy might be considered. So that's kind of the second tier on our step-up approach to pancreatitis. So endoscopic therapy, for those of you who are maybe less familiar with that, that's basically a scope that goes down into the pancreatic duct, or it's also called ERCP. And it can be used to remove stones or to put stents across strictures. But it's really when patients are failing these first two approaches, medical therapy and endoscopic therapy, if appropriate, that we consider surgical procedures. And TPI T is one of the primary surgical procedures that we would consider for someone who has disease that involves all of their pancreas, or diffuse disease, meaning we can't just take out part of the pancreas to treat that. And also for patients who have a small pancreatic or normal-sized pancreatic duct, because some of the procedures to drain the duct surgically are not feasible in that situation. So when we're evaluating a patient for TPIAT, we're basically kind of going through a list in our mind of what we're looking for that would merit TPIAT as the next approach, or a possible next approach to treating the pancreatitis. So obviously the very first thing that we're evaluating for is that the patient that we're seeing does have severe chronic pancreatitis or acute recurring pancreatitis, and that's actually what's causing the abdominal pain. So we want to make sure that we've adequately eliminated the possibility of other sources of pain. And the TPIT surgery is a pretty major surgery, and so we don't want to do this for a mild case of chronic pancreatitis. But the pain for the patients that we see has to be severe enough that it's actually causing some disability, and that might depend on who you're talking to, how you define that. Depends a lot on how the patient perceives that, but that might be missing school frequently, missing work, not being able to engage in normal kind of family life, or it might be a situation where perhaps you can do some of those things, but you need opioid therapy to do that. So it's resulting in dependence on opioids, which are not a great lifelong medication to be on. For the Islet Auto-Transplant part of the procedure in particular, preferably someone going into the surgery would not yet have diabetes, and for sure they need to have some functioning islets. So they need to have islets that are producing insulin in order for us to be able to rescue those islets and give them back. So we look for functioning islets, and we have some lab tests we can do for that. And then we look at general health. So it's a really big surgery physically, and a really big recovery mentally to go through TPIT surgery. So we want to make sure any physical conditions, mental health conditions are adequately managed so that surgery can be safely performed. And at our institution, this does include that we ask people who are smoking to quit smoking before they get to surgery. Not an easy thing to do, but it's really important for surgical healing, for engraftment of the islet. So there's some really important reasons why we recommend smoking cessation. And then, of course, at the end of the day, this is a really big surgery, and there's aspects to the surgery that are completely irreversible. So you have to go through a long recovery process. We take away the digestive part of the pancreas, so you have to commit to lifelong pancreatic enzymes, and you're committing to monitoring for diabetes and diabetes risk. So a patient obviously has to be willing to go through that process in order to have this chance for pain recovery and restoring quality of life. So a very common question we get is, I clearly have chronic pancreatitis. How early or when should I be considering TPI T? And it is a tough question. And it's a tough question because everyone's different and everyone's disease is different. So it really does depend on the individual, how aggressive their course of pancreatitis is and the cause of the disease. So by that, I mean that it depends on how aggressively the individual wants to treat or go to surgery. The pancreatitis course can be very, very different for very different individuals. So sometimes we see very rapid progression, and sometimes we see people who have had pancreatitis for 20 years, but it was mild for a long time. And the cause of disease, sometimes we will consider whether someone has a genetic cause underlying their pancreatitis. So if we know that someone has hereditary pancreatitis and that's likely to progress, we may be opting to intervene a little bit earlier. But there are some disadvantages to early intervention. We're putting someone through a major surgery that has surgical risks associated with it and requires lifelong care afterwards. So you're really committed once you get to TPI T surgery. The advantages, on the other hand, to going to TPI T earlier is that you've had less chance for scarring in that pancreas. So we think we're able to better preserve islet mass in that setting. So islet mass meaning the number of cells that are there to make insulin for your body, which results in better diabetes outcomes. And we think someone who has had a shorter duration of having kind of chronic pain, especially chronic daily pain, has a better chance for more complete pain relief because they may have less damage to that central nervous system that carries the pain signals. We also try to stay away in general from performing a partial resection or a surgical drainage in patients who are likely to go on to TPI T, because we do know that islet auto-transplant, the diabetes portion of the procedure, is less successful if other surgeries have been performed first. So very briefly, I'm going to talk a little bit about what's involved in the surgery process, and I want to highlight here that the main goal is pain relief. So the primary surgery here is the pancreatectomy. For patients with chronic pancreatitis, we're taking out the pancreas with the goal to relieve pain and thereby improve quality of life. And a secondary goal is the islet auto-transplant. So we know we could just take someone's pancreas out, but they would make no insulin of their own, and they'd be a lifelong insulin-dependent diabetic, a type 1 diabetic, essentially. And so we're trying to give some of those islet cells back into the patient, and usually that's by infusing them into the liver, the portal vein of the liver. And the goal there is to either be able to prevent diabetes after surgery or to at least minimize the severity of that diabetes so that it's easier to manage. So this is a really complicated surgery. The pancreas is unfortunately anatomically difficult to remove. So obviously the surgery involves removing the entire pancreas, but it also involves removing some of the anatomy around the pancreas, and that has to do with the blood supply. So the pancreas shares blood supply with the duodenum and a vein with the spleen. And so in order to take the whole pancreas out, we need to take out this little piece of the small intestine called the duodenum. We need to reconnect then the intestines and reconnect the bile duct from the liver to the intestines. And usually the spleen is also removed because of that splenic vein being sacrificed by the pancreatectomy. So in the figures on this, you can see on the left side the anatomy beforehand and a schematic of how the anatomy might look afterwards. Now this procedure, in terms of how the plumbing gets put back together and some of the details, may differ a little bit depending on the surgeon and the center performing the procedure. We also know that it's really hard to eat normally for the first few weeks after the surgery. So considering a patient's nutrition is actually a really important part of the surgery process, because having proper nutrition is important for recovering from surgery. So patients at our institution may have a feeding tube for about a month or a month and a half after surgery to help get their nutritional needs met while they're recovering from surgery. So how about the islet cell processing part and the islet transplant part? Well, these are graphics that come from our islet isolation facilities. What I always tell patients is there are really two teams that are involved in the TPI T surgery, and one of them is the team doing the surgery, and the other is the team that's coming to pick up the pancreas and taking it to do the islet isolation. So this is a special sterile facility that is compliant with certain requirements from the FDA for processing human tissue. The graphic up on the left-hand corner is a pancreas. I have to say that's actually a deceased donor pancreas in the example. So a chronic pancreatitis pancreas would look similar but much more scarred. The very first thing they do is cannulate the pancreatic duct, and they infuse an enzyme solution called collagenase through the pancreatic duct. That way it distends equally throughout the pancreas. And basically what this enzyme solution called collagenase does, it digests collagen. Collagen is kind of like the soft skeleton that holds our pancreas together. So when the pancreas is loosened up, so basically the islets are loosened up from the surrounding digestive tissue, that pancreas is placed in a special chamber that's on the lower left hand. We call that a Ricordi chamber. And it's a process what we call mechanical digestion, where the pancreas is actually shook back and forth, and it really looks kind of like a liquid slurry form of pancreas tissue, and that's what the islets are collected out of. So that figure that's in the middle, the lower, that's basically what an islet auto-transplant graft would look like, where the islets are stained red, and there is a little bit of gunky residual exocrine tissue that goes with the islets. It's a very small amount of tissue, though, usually about a tablespoon or so of tissue at the end of the day. So the primary place where we put these islets is to put them into the liver. It's a pretty easy site to access for transplant. The surgeon will put a little IV into the portal vein, and the islets basically drip into the portal vein, and they follow the blood flow into the liver, into smaller vessels called sinusoids, and that's where the islets get stuck and kind of start to engraft and function over a few months. This initial inflammation or infusion does trigger an inflammation process, so the islets are somewhat damaged at the time that they're infused, and the islets must take some time to make a new home in the liver. That includes recovering from that inflammation and developing some new blood supply from the liver. So we call this the engraftment process, and it's taking a few months for those islets to engraft in the liver. And they're not really working fully initially, but once they're fully engrafted, those islets will work like they did in the native pancreas. They will sense the blood glucose, or what we would also call blood sugar, in the blood flow around them, and then they will release insulin, more insulin when the blood sugar is higher, and then they'll turn it off when the blood sugar goes low. So they work in that liver environment much like they would in the pancreas. So this is a pretty complicated procedure, and as you can tell, there are a lot of elements to it. So it really does truly require a huge multidisciplinary team. This photo is actually our team at the University of Minnesota, and exactly who the key players are might vary a little bit by the institution you go to, but it should include surgeons and gastroenterologists and endocrinologists and pain doctors and pain psychologists is probably the key players. And then there's ancillary staff that are involved around those key physicians, including physical therapists that may help prepare a patient for surgery or help them rehab from surgery, dietitians to address the nutrition part through the surgery process and then afterwards, and the pancreatic enzymes. Obviously, we need the islet team to help with the processing, and because there are so many teams involved, typically there's a nurse coordinator who helps coordinate all those different teams. And on a case-by-case basis, depending on other comorbidities, there may be other physician players that are involved in the process. And of course, two very important key players long-term, the local primary care provider who is going to be helping provide ongoing care under our guidance post-TPI T is a really important part of the team, even if they're not there in the early part of surgery. And the patient support system is a critical part of the team. So this is not the type of surgery where you can just sort of give someone surgery and they get better. It really involves a lot of commitment and work and interaction on the part of the patient. So they're a key part of that team. So what should you expect if you're thinking about going through the surgery process with TPI T? Well, of course, this will depend a lot on the individual person and where you're at. So these are really general guidelines. But in the first couple months after surgery, generally people will be in the hospital for on average somewhere around 10 days to 2 weeks. Some patients, particularly maybe children, might be in just a little bit longer than that, or someone who has a complication may end up in a little bit longer. But this first month or 2 months after surgery is really the highest risk time for getting an acute surgical complication, early surgical complication like infection or bleeding. And so particularly at our institution, we have patients keeping very close to the hospital in case there's a problem that we need to manage quickly. But at the same time, kind of on the outpatient side, when someone gets out of the hospital, we're focusing on post-surgical pain management, which, as you can imagine, can be complicated, nutritional elements, so getting people back to eating a regular diet. And there's a lot of adjustments in insulin and diabetes management during that time period. So it may depend on the center you go to, but know that if you're traveling from a distance, the surgeon may ask you to stay locally during that time for close monitoring. But it takes longer than that, obviously, to fully recover from surgery. And so you should expect that the surgery recovery process is probably going to take that whole first year. It's a long process, and for some people, it may take more than a year. And what are the things happening during that time? Well, there's sort of this, early surgical recovery, but after that, you're still working on weaning from pain medicines, still working on weaning from insulin if it's possible and safe to do so, and that usually takes at least a few months and sometimes a year or more to wean off fully. As someone transitions to a regular diet and they're eating more, it's very common for us to have to adjust the dose and the timing and the type of pancreatic enzymes. And we're following, not just in the first year, but beyond, but particularly in the first year, we're following nutritional markers, fat-soluble vitamins, other lab markers of health and surgical recovery. Do expect that if you have TPI T, there'll be lifelong medication management with that and labs and assessments that you'll have to undergo. So from the medication side, everyone who has the surgery for the rest of their life should be taking pancreatic enzymes with every meal and with snacks. Most people will actually get sick. If they don't take them, they'll get abdominal cramping, diarrhea, bloating, and symptoms that are uncomfortable. But even beyond that, if you are not getting pancreatic enzyme therapy, even if you have relatively mild symptoms, you're probably not getting your vitamin A, D, E like you should, so you have malabsorption issues, even if you're mildly symptomatic from them. We do recommend that everyone stay on a multivitamin. There are some multivitamins that are intended specifically for people who don't have a pancreas or don't have a functioning pancreas, and we like to use those early on. But lifelong, sometimes any multivitamin becomes adequate, but you should be on something. Because the spleen is going to come out or may come out, you should be covered with vaccines that protect against certain bacteria that are recommended for asplenia. Most of our patients are on proton pump inhibitors, at least for a year and oftentimes longer. Insulin therapy is a given, at least for the short term. So 100% of patients get treated with insulin after surgery, and some wean off, and some require long-term therapy. And then there's a number of medications that are used for at least a few months after surgery, particularly pain medications, oftentimes aspirin to prevent blood clots is needed for a while after surgery. And then patients are coming in relatively frequently for lab assessments. At our institution, we typically do 3, 6-month, 1 year, and yearly lab assessments that look at nutritional factors, diabetes and islet function, liver health, blood counts. And your surgical center should have a guideline or a protocol that they can provide to you and your local care provider to help guide that. So I'm an endocrinologist, so of course I deal a lot with how to manage diabetes after TPI T, and some of you may be more familiar with diabetes than others. But obviously the mainstay of diabetes management for this type of surgery is insulin, because the primary problem after surgery is your body not making enough insulin. And so usually early on we'll manage that with insulin shots with what we call insulin pen devices. Most people to start off will have 2 types of insulins, a long-acting and a rapid-acting. But sometimes long-term people will be able to wean to a point where they're just using a single dose a day of a long-acting insulin. Other times people are staying on taking a long-acting insulin plus taking a rapid-acting insulin with each meal time. We do have a number of patients in our population who use insulin pump therapy. In fact, we've introduced this as the routine in children. So early after surgery now, we start patients on an insulin pump very early in the hospital. And the rationale for that is actually because with children, we can deliver very small doses of insulin that we oftentimes need and can't do adequately with insulin pens. But we also have a number of adults who will decide to transition onto an insulin pump long-term because they have to remain on multiple daily injections, and it certainly is very convenient for many people to do an insulin pump. Now, I should say, because some people ask me, an insulin pump is all external. There's nothing surgically implanted, but you just kind of are wearing your insulin on your body, and you have a computer program to help you calculate and deliver the insulin doses. Everyone also needs a way to monitor their blood sugar, and the conventional way is to use blood glucose meters. So everyone has a blood glucose meter. We have more and more people now, depending on how much fluctuation they have in their blood glucose, who might be using a continuous glucose monitor, which is the photos on the lower left where you actually wear a sensor around all the time. So we're getting more and more technology to help with diabetes management, which is really making diabetes more livable. But of course, probably the most important thing for people coming through this surgery is pain relief, because the primary goal of the surgery is to reduce pain burden. And, you know, in a wonderful outcome, we can reduce that pain burden to an absent level, but some little bit of low-level residual pain is really common. I'll talk about that in a subsequent slide. In terms of general statistics, if we look at our institution in particular, and we've studied this for a number of years, 85% of patients undergoing TPI T will identify their pain burden as significantly improved after surgery. On the flip side, that does mean about 1 out of 8 people who go through this big surgery process actually say that they have a similar pain burden after surgery as they did before. And that may be because they have another cause of their pain, they had a surgical complication, or they have some changes in the nervous system that are giving them chronic ongoing pain. And opioid weaning is really a challenge, but it's really important. So we do still see up to 40% of people using some opioids at 2 years after surgery, particularly people who have been on them for a long duration beforehand. But we do really try whenever feasible to wean off opioids very slowly over time, because we know that helps with the recovery of the nervous system and the pain nerves. And because we're improving pain control, we also see an improvement in quality of life. This is statistical averages of quality of life in these pictures by a standard metric called the SF-36 that looks at mental and physical functioning. And so we see a pretty substantial improvement on average in adults and children. The children tend to have a little bit more of a dramatic improvement as a group, as a whole, but we certainly see improvements on average in both age groups. But of course, one of the challenges is that we do see people who still have ongoing pain, so I think it's really important to mention this, and people will say, well, my pancreas is gone. Why do I still have that type of pancreas pain, either at a low level commonly or kind of at a more severe level intermittently? And when we do pancreatectomy, we are removing the cause of the initial pain, but unfortunately the pain pathway is somewhat complex. The figure on the right is obviously not a pancreas, but it kind of shows the pathways. You have the site of injury, which in this case is the pancreas, where the nerves come in. They have to meet with the nerves in the spinal cord that then carry the pain signal up to the brain and meet the brain neurons to transmit that pain signal. And unfortunately, what happens over time is your body with chronic daily pain or recurrent pain really trains these pain nerves to become very efficient. It's like training to be an elite athlete, except you're training your pain system. So it generates something called central sensitization, where sometimes those nerves continue to fire abnormally in the spinal cord and bring the same pain impulses, even though your pancreas is gone. And sometimes opioids can perpetuate this cycle, something known as opioid-induced hyperalgesia. And finally, how likely is it that I'll have diabetes after this procedure? Well, it's a 100% chance that you'll use insulin, at least for the short term. So everyone undergoing this procedure has to be prepared to use insulin. And about 40% of patients will come off insulin after surgery at some point, but about 60%, so a little bit more than half, will remain on insulin lifelong. So there's a little bit of a bigger chance of remaining on insulin than coming off. Now, most of those patients do have some cells working for them, just not enough to come off. And it does depend on how many you get. So that bar graph on the left is number of islets transplanted, kind of very simply outlined as low, middle of the road, or high islet mass transplanted. And if you get a high islet mass, the orange bars, it's about a 70%, 60 to 70% chance of coming off insulin. So more islets, the better. And less islets transplanted means you're more likely to have to stay on some insulin. So to wrap up my part, what should you do next? If you're hearing this presentation, you think, well, I want to learn more about TPIAT. First of all, know that TPIAT is not the right fit for everyone. So if you hear this or you look up more information, you decide this type of major surgery is not for you, that's okay. And you may not be at the point where you're ready for this yet. But if you're interested in learning more about TPIAT for your case in particular, I would encourage you to talk to your own pancreas doctor about TPIAT. If you think it's appropriate, seek a consult at one of the centers performing TPIAT. And I think always remember that seeking a consult doesn't mean you're going to have surgery. Probably about half of patients at our center who seek a consult will actually end up having surgery. So the consult is a process of being evaluated, determining whether you might be a candidate now or in the future, and actually getting more information on what the procedure involves. There's a number of places on the web that will have more information. This is our particular link to one of our sites right here. Certainly other centers that perform the surgery may have information, and places like Mission Cure, the National Pancreas Foundation are always reliable sources to go to. If you have questions after this procedure that we don't, or after this presentation that we don't have time to get to, certainly feel free to reach out to me as well through the folks at Mission Cure.
Great. Thank you, Dr. Bellin. We are getting questions coming in, and I want to encourage the rest of you, if you haven't typed your question, to go ahead and type it in the Q&A box, and we will get to those in just a few minutes. But first, I'd like to introduce Amy Jensen, a patient who suffered with acute, recurrent, and chronic pancreatitis and had TPIAT surgery just about 8 weeks ago. In full disclosure, Amy is my daughter, and I am very proud of the courage she demonstrated and taught me through her journey with pancreatitis. And now, Amy.
Thanks, Mom. Hi everyone. Like my mom just said, I'm about 8 weeks out from having the TPIAT surgery. I am still very much in recovery, but I am doing pretty well so far. To tell you how I got here, I'll give you sort of an abridged version of my history of chronic pancreatitis, or CP. So I had digestive issues my whole life, but they were relatively minor and short-lived until about 5 years ago. It started with indigestion and acid reflux that occurred more and more frequently and lasted longer and longer. Then the nausea and vomiting started, and I would throw up stomach bile for days at a time. I couldn't eat or drink anything when this was happening. My doctor said to take more Zantac, and then I had something called acid stomach. I ended up taking 5 to 6 Zantac a day until I saw a new doctor who put me on omeprazole instead. It helped, but not much. In January of 2017, I was diagnosed with pneumonia, but 2 rounds of antibiotics didn't help my symptoms, and I kept getting sicker. At that same time, I started having back pain that wouldn't go away, and it just got worse and worse. I blamed it on the pneumonia and just thought I was taking a long time to get over it. But by June of 2017, the pain was unbearable. I couldn't get comfortable or sleep, and I felt sick all the time. I could hardly eat, and I had lost 100 pounds in just over a year. I was down to 110 pounds, and while some people thought I looked better than ever, I felt like I was dying. I went back to my doctor, who sent me for a chest x-ray, and within hours, called and told me to go to the ER and tell them that I had pleural effusion, or fluid in both of my lungs, and that it was very serious. That ER visit in June 2017 changed everything. They didn't pay much attention to my lungs. Instead, they said it looked like I had pancreatitis, causing fluid to build up in my abdomen that was then leaking into the lining of my lungs. But it was the pancreatitis they were concerned about. However, they were openly confused, saying that my labs didn't support that diagnosis. They referred me to a GI and sent me home. I had never heard of pancreatitis and didn't know if they were saying I had it or not, or what was really wrong with me, but I knew something was seriously wrong. I had a week until that GI appointment, so of course I started Googling. I learned enough to become pretty convinced that I'd had this for years and to be scared because there didn't seem to be any cure. I had a CT scan and went to that first GI appointment where I was rudely told that I probably did have pancreatitis and I just needed to stop drinking. Well, I hadn't had a drink in months and wasn't an alcoholic before. I knew enough to know that this doctor would not help me. Desperate for help, I went out of state to one of the top medical facilities in the country, where I spent 2 weeks getting test after test, including an ERCP and biopsies of my pancreas. This was all while in an acute pancreatitis flare the whole time. Not one doctor recognized, or at least they didn't acknowledge that. But by the time I left, I had a diagnosis. I did have chronic pancreatitis, and despite just being diagnosed, it was severe and had been going on a long time. My acid stomach, which by the way doesn't exist, had in fact been recurrent acute pancreatitis episodes. I now had 4 pseudocysts with calcifications throughout my pancreas. They also gave me another referral to a GI in my own state, a pancreas expert, but I was disappointed that he had no plan beyond diet changes and no smoking or alcohol. I was in the hospital off and on for the next 3 months. Until November of 2017, they identified that 1 or more of my cysts was leaking and that the fluid in my abdomen was infected. I had an ERCP with sphincterotomy and stent placement. My GI told me that if I kept eating low fat and didn't drink or smoke, that I would slowly get better, though it might take years. It horrified me that my pancreas expert doctor would say this because I knew it wasn't true. Chronic pancreatitis does not get better. But I also wasn't okay with a life in pain and being sick all the time, so I kept looking for an answer. During my research, the only thing I could find that might make me feel better was the TPIAT. But it seemed people waited as long as possible to get this done, trying everything else, having multiple procedures that either fail or only last temporarily before they even consider it. My own GI said it would be malpractice for anyone to even consider it for me so early. But everything I could find suggested the earlier the better for the best results, especially when it came to ending pain and not being insulin dependent. I couldn't think of a reason to wait, and I had every reason to at least see if this was the right answer for me. So in August of 2018, I called the University of Minnesota Transplant Department and said I would like a consult for the TPI T surgery and that I was referring myself. I spoke with the coordinator at length, and she was the first medical professional who actually seemed to understand CP that I had ever encountered. I sent them my entire medical chart, including imaging, as well as their questionnaire asking why I wanted the surgery and what my goals were. As Dr. Bellin said, there are a lot of departments involved, and over the next week, they reviewed my information individually, and then they met collectively to determine if they believed the surgery might be the best answer for me. It's a large and complex surgery, and no one wants to do it unless they really believe you will have a better life after than before. I received the call that they thought that might be the case for me and that the next step was to go to Minnesota and meet for an in-person assessment. So that last week of September of 2018, my mom and I flew to Minnesota to find out if I could actually be free of chronic pancreatitis. The assessment involved meeting with someone from each of the departments, including the surgeon. This was my chance to ask them all of my questions, as well as for them to make sure that I understood the risks and possible outcomes for this surgery. They did a CT scan and some blood work, but mainly I just talked to the different members of the team. It was 2 days of meetings, and when I left, I knew that I wanted the surgery, and I just hoped that they would think it was right for me. A week later, they called and said I was a good candidate and that it was time for my pancreas to go. So it was scheduled for about 6 weeks later on November 16th. I arrived a few days early for pre-op activities. It was mainly paperwork and a boost test where they hope to get an idea of how your islets are working, but there are no guarantees. I also met with each member of the team again. Those few days before surgery, I'll admit, I was very scared and nervous, but I just kept telling myself it was better than a life of guaranteed pain. Well, the surgery ended up being more complicated than expected. There are some things they can't see on scans, and they said my stomach was plastered to my pancreas and spleen because of all the inflammation and leaky pseudocysts. It was difficult to separate my pancreas from everything else, and they ended up taking part of my stomach and a little more intestine than usual. They also removed my gallbladder, spleen, and appendix, which is pretty normal. However, they did find that I had splenic vein thrombosis, which can cause severe internal bleeding, so it's very good I had the surgery when I did. Unfortunately, I didn't have it soon enough to get a good islet yield. They hoped to get at least 200,000 islets, and I only had about 22,000 to give back to me. This means I am now type 1 diabetic and insulin dependent, but I knew that was a risk going in, and I still think it's a good trade. I could manage diabetes, but I could not manage chronic pancreatitis. My surgery took about 13 hours. That is a very long time to be under general anesthesia, and I'm not going to lie, waking up from the surgery was rough. I was confused and hooked up to what seemed like 100 tubes and wires. I was on massive amounts of pain meds, and while I wasn't in much pain, I did have hallucinations and confusion for the first several days. I don't remember much from that time. They changed my pain meds, and the hallucination and confusion left, and I felt much better. My pain continued to be well managed, and the team was really responsive when I needed anything. Every day I was visited by the surgeon, someone on the surgeon's team, an endocrinologist, and many nurses who helped with everything from getting me to and from the bathroom with my IV pole to taking my blood sugars. I walked every day on the advice of many who had had the TPI T before me. I started to have clear liquids instead of just ice chips. It was time for me to go, and on my 9th day I was discharged, and my mom and I went to a local hotel to stay for the next 4 weeks. Being discharged was overwhelming because I had a feeding tube and a wound drainage tube attached to me that I now had to manage, as well as administering all my own meds through the feeding tube and changing my dressings daily. But after what felt like a fumbling first day, I felt like I could do it. I had made some mistakes and I had a lot to learn, but I knew I could handle it. I continued to walk every day, and I do think it helped a lot. I started to eat soft foods just a couple days after discharge, and I didn't have any digestive issues, so they reduced the tube feeds, and I started eating solid foods. It was a little earlier than most people, but the feeding tube was causing me pain, and since I was handling solid foods so well, the feeding tube was removed just a few days later. That was a big deal to me because I was no longer connected to anything. One of the big adjustments after the TPIT is diabetes. There was a lot of monitoring and tracking of my blood sugars and administering long and short-acting doses of insulin. I emailed Dr. Bellin my blood sugars and what I ate every day, and she made some adjustments if needed. There were more in the beginning, but I am still emailing her the data, and she still makes adjustments sometimes. Luckily, I've been pretty stable overall. I was able to leave Minnesota a few days before Christmas, which was awesome. While the team at U of M remains a resource to me and my doctors as needed, I have local doctors treating me and had those set up prior to coming home, except of course endocrinology, or Dr. Bellin in my case, who I still email regularly. Eventually that will transition fully to my home endocrinologist. My next step is to look into insulin pumps and continuous glucose monitors, which will help make diabetes even easier to manage. But many people who have the surgery don't need that, as they will come off insulin instead. For me, the most important outcomes of the surgery are that I don't have pancreatic type pain anymore, I don't have nausea or vomiting, and I don't feel sick every day. My appetite is back, and so far I can eat anything I want to with enzymes. Also, what was a greatly increased risk of pancreatic cancer is now 100% eliminated. It is still early in my recovery, but I hope it continues as well as it has been. I don't have any regrets at all, and if I could have done it earlier, I would have. Thank you for listening to my story.
Thank you, Amy. And thank you again, Dr. Bellin. Now it's time for your questions and ideas, and I see we've had a lot come in. Joining us now to moderate our Q&A session is a member of our mighty team that I mentioned earlier, Robin Yates. Thank you, Robin.
Hi, everybody. I know we're running out of time for some of you. We will stay on after the call is scheduled to end and answer as many questions as we can. Please note we have a number of questions that have already been submitted, and if we don't get to them all, we will follow up with a post-webinar Q&A document that we'll share on our website. While, as you can tell, Dr. Bellin and Amy are very knowledgeable about TPIAT, please know that patient-specific questions will be need to be handled, in a general way or offline. So let's get started. Dr. Bellin, our first question was, why can't we transplant a pancreas?
Yeah, that's an excellent question, one we get quite a bit. And so I'll start out saying that there have been patients who have had a pancreatectomy and a failed islets or weren't able to get islets who later ended up having a pancreas transplant. They're kind of few and far between. And the reason for that is that the pancreas transplant, when you talk about pancreas transplant, you're actually talking about taking a pancreas from a donor, usually someone who's died, who donates their organs, and then putting it in someone else's body. So you actually need, in addition to a more major surgery, you need medications that suppress the immune system so that your body doesn't reject that. And then those medications can have some side effects too. So there wouldn't really be a situation where someone would do a transplant at the same time they're taking a pancreas out, because the risk for infection and complications would just be much too high if you had to be on immunosuppression at that time. But for a few people who really have struggles with diabetes, things like having seizures from low blood sugars and just a very difficult to manage form of diabetes, there might be rare cases where that's considered later down the road. For people who are actually doing really well after the TPIAT and can manage their diabetes and are feeling okay, there's not really a reason to do a pancreas transplant, because it'll actually give you more problems.
Great. Our next question is, can TPIAT be done for early stage pancreatic cancer patients? Why or why not?
So also a very good question. So there is one center, not in the US, there's a center in Milan, Italy, that is doing some IAT procedures in patients with pancreatic cancer. They're sort of very highly selective, so there are usually patients who have had surgical complications from pancreas surgery, partial resections of the cancer, and then they need to have like a completion pancreatectomy because of the complications. And they have been isolating islets from that good non-cancer form of part of the pancreas and then transplanting those back into the liver. And they have reasonably good data that they've been able to do that safely in a very small select group of patients. But it's, you know, it's a real concern because we don't want to give pre-malignant or early malignant cells back into someone's liver, because we'd basically be giving them metastatic disease. And so in the US, we've largely avoided doing any islet transplant, islet auto-transplant procedures in patients who have cancer or who may have cancer.
Great. So our next question is there a way to predict how many islet cells will be retrieved prior to the surgery? Any kind of indicator to give you an idea through a blood test or anything of that sort?
Yeah, we have been learning more and more about that, and there are some tests that we do beforehand that help give us an idea in a general sense as to whether we expect that this may be a moderate to high islet mass or a low islet mass. What we're not very good at, honestly, is predicting for an individual patient a very precise number. So it would be very difficult for us to say, we think you have 150,000 or 200,000 islets and do that with any precision. But we are able to some extent look at if the glucoses are normal, if the C-peptide, which is the marker of insulin secretion, goes above a certain threshold, whether or not we expect that we would get a reasonable number of islets out of that pancreas. So there are some markers we can look at. They're not as wonderful as I would like. I'd love to be able to tell people exactly how many islets they have before surgery, but they at least give us some idea of what might happen. Now, the caveat to that is that even some patients who get a lot of islets transplanted, they don't always survive the process. So what we can't predict, even with the islet number, is how many are actually going to make it through and survive the transplant process.
Well, and this next question is kind of connected to that. Are there tests or procedures that can be done to help predict whether someone will have a good response to TPIAT in terms of pain reduction? You know, for example, a celiac nerve block?
Yeah. So we are actually studying some approaches to that. So there have been some data that come out of patients in Europe who have had a different type of pancreatic surgery, suggesting that there may be some specialized tests we can do that sort of basically figure out at what pressure and what temperature the nervous system perceives pain. And that those might be predictors for people who respond. But we're just now starting to study some of those markers at Minnesota and Hopkins and some of the centers in the US, starting to study those markers on a research basis, those tests on a research basis. So as of right now, we don't have any good tests that can actually predict who's going to have residual pain. I personally do feel reassured for when I see patients who are having flares of pancreatitis, but they actually have pain-free days. That to me is a relatively reassuring factor, that they have days where their nervous system is working okay and they don't have that residual pain. But it gets a little bit tougher, I think, to decipher in people who have chronic daily pain with their pancreatitis.
Okay. Actually had a couple questions on this front. There's one person online, a patient who successfully had the surgery 18 months ago. And these questions are connected because they're wondering over time, does the research show how long islets might do well after surgery and whether there's a downturn after a while? As in, how long do the islets function within the liver? Do they live within the liver? Or do they have
and it's a really good point, because one thing I didn't say, but I always tell patients, is that based on our current knowledge, we don't expect those islets to work well enough forever in the liver to keep people off insulin forever. So we do think that over time, in that environment that's different than a healthy native pancreas, and that liver environment, that there's a slow sort of loss of islets. We have a handful of patients who have made it out to about 14 to 18 years off insulin. 18 years is recently the longest case we've heard of, but no one longer than that. We have about, of our patients who have at least 10 years of follow-up, about 10% of those patients are off insulin at 10 years. So we know for many patients, this will be kind of a several year to maybe, 4 to 5 year period off insulin, and then having to go back on some supplemental insulin. And I actually have my patients always doing some blood glucose monitoring, even if they're off insulin, because I think if you can intervene quickly, if you see that you're getting to the point where you need a little supplemental insulin, if you can add a long-acting insulin right away, that actually can keep the diabetes easy to manage for many years.
That's great. And I realize it's the top of the hour, so we appreciate if people have to drop off, but we will stay on for a number of minutes later just to make sure we answer some remaining questions. So thank you if anyone has to drop, but please do. I'm going to put into our chat box during the next answer here a survey that we really will help us fill out. By filling out the survey, you not only help us continue to provide great content, but you also help us prove that these webinars are worthy for our sponsors, so we can continue to bring great resources like Dr. Bellin and Amy to you on a regular basis. So with that, I'll move on to the next question. Is there any data available on the impact of the surgery on life expectancy?
Yeah, that's a really great question. It actually ends up being very complicated, because historically some people who've come in for the surgery are pretty sick by the time they get to us, and we see patients of all different age groups. So actually, if we looked recently historically, and the 10-year survival after surgery is actually somewhere around 80%, but a lot of that has to do with patients who had surgery in the early days where people were sicker when they got here. Chronic pancreatitis in and of itself has a shortened life expectancy relative to the normal population. So when you compare it to chronic pancreatitis, I actually think it doesn't look too much different. But in theory, someone who recovers from surgery and has adequately managed diabetes and is taking their pancreatic enzymes, so in other words, we're adequately replacing all the functions of the pancreas, they should have a normal, healthy life. Complications like diabetes complications have to do with high blood sugars and poor control. So we think that's all stuff that is manageable after surgery.
That's great. Okay, this next question, changing tune a little bit, can women sustain healthy pregnancies after this surgery?
Yes, yeah. So it's more complicated to have pregnancy when you've had this surgery, but we have a number of women who have done it and have healthy babies. When I say it gets complicated, it is probably primarily because of the diabetes aspects that it gets complicated. So you probably are familiar with the term gestational diabetes. When women are pregnant, particularly during the second and third trimester, their body is what we call more insulin resistant, and then they have a higher insulin need. So women who have had this TPI T surgery, even if they're off insulin at the point that they get pregnant, they have to be really monitored pretty closely, because probably everyone is going to need some insulin during pregnancy, and people who are already on insulin are going to need higher doses of insulin. And obviously you want proper nutrition for pregnancy, so we want to make sure pancreatic enzymes are appropriately adjusted, that people are having things like their vitamin D level followed. But certainly if you're addressing all of those factors, you're watching blood sugars from early in pregnancy, treating appropriate with insulin, the women who we've seen go through pregnancies have had very good outcomes. So it is certainly feasible to do. It just ends up requiring some pretty specialized medical care through the process.
That's great. So this next question or comment is actually a really important one. Somebody just wrote in, I wish we had this webinar 2 years ago before I had surgery. If you're on this call, you probably know of people around you that are inflicted with this terrible disease. We're hoping that you can help us get the word out. So when this webinar and our previous webinars already available, but when this webinar goes live, you can share it with your friends and your communities, and we'd ask that you please do so. And we're thrilled that you're getting value from our webinar.
Yeah,
so,
and that's a really good point. I think we have some people who find us as a surgery center on their own, and other people that are referred by physicians, but it isn't something that people always know is out there as an option. So I think that is a good point.
So next question, how do you think TPIAT may change or evolve in the future? Do you see a growing number of centers performing this procedure? I know we already mentioned there are about 15 in the US. We got a question about, are there centers in Canada as well?
Right, yeah. And it's always a little hard to track because you don't have to report your TPIT cases to any public database. There is the Collaborative Islet Transplant Registry. So I don't always know exactly who has performed procedures in the past year, but that's kind of the approximate estimate. In Canada, there are a couple centers that do islet transplantation in general for type 1 diabetes, and one of those big centers is in University of Alberta at Edmonton, and I know that center, it's Dr. James Shapiro is the surgeon there, specifically does do some cases of TPIT. I'm not sure about the other centers in Canada. There's one in Vancouver, but whether they're doing TPIT or not, I'm not sure.
Okay, great. And as a reminder, in the chat window, you have the link to our survey. So please do click and just give us a few minutes of your time to let us know other topics even that we can be including in our webinars. I've gotten a couple questions here about the proton or protein pump inhibitor.
Oh, right. Yes, so that's very good. So I'm glad someone's catching me on my medical language and asking for clarification. So the proton pump inhibitor, it's an acid blocker. It's like Protonix or Prevacid or Nexium are probably the brands people are familiar with. And it came up in the medication section because we keep everyone on a acid blocker, preferably a proton pump inhibitor because they're the most potent, for at least a year after surgery. And that is because it helps prevent ulcer formation at the place where the gut is put back together, the intestine is put back together. And also because having the acid blocked is usually helpful for the enzyme efficacy as well. So a couple of reasons for that.
Okay, and another question is around timing. Amy had mentioned how long her surgery took. The timing is actually a twofold question here. One is what's typical for the length of the surgery, and also in terms of the timing of the surgery itself. Some people are writing in, is it good to wait? Is it good to have it earlier versus later?
Yeah, and that's where I think you actually probably need to take that on a case-to-case basis. For someone who's going to definitely need TPIT, there's clearly a rationale to intervene earlier to get better pain and diabetes outcomes. But I don't think it's always very clear early in the process that someone's down that path. And so we really see a spectrum of patients in terms of where we intervene. It kind of depends on their preferences and where they get to us. We have patients where they're kind of like Amy, where maybe they have a pretty short duration of diagnosed disease, a year or so, but they probably had disease much longer that went undiagnosed. In terms of duration of actual disease, diagnosed or undiagnosed, most people have probably been having episodes for at least a couple, 3 years before they kind of get to this point of surgery. But it does depend on how intense and how quickly things are progressing. We have patients who will come to us who are, having 5 or 6 episodes a year, but they're pretty well in between. And we have some patients who have gotten to the point of having pain every day. So it's really a spectrum when people get there. But if you're to the point where this is clearly the path you're taking, then I do think that there's a rationale for going earlier rather than waiting.
Okay, we'll just take a couple more questions here. This next one, how much does the surgery cost and does insurance cover it?
Yeah, I'm glad someone brought that up because that's a really good question. So The surgery cost is actually a more difficult one for me to answer than the coverage one. So I'm going to start with the coverage. So it's covered by most private insurances. We usually are able to get private insurance patients in for surgery. Where it gets more complicated is Medicare and Medicaid. So straight Medicare does not cover the islet transplant portion of the procedure, only the pancreatectomy. Although we do have some patients who have supplements to Medicare who are covered, but the traditional Medicare plan does not cover the islet auto-transplant. And state Medicaids tend to be somewhat variable in terms of whether they cover it or not. So we do have a number of medical assistants or Medicaid patients who have come to our institution. So the whole surgery is probably, if you were going to pay out of pocket a couple $100,000, the islet transplant part itself is actually quite expensive. You know, somewhere in the range of $60,000 to $70,000 to get the islets isolated, the lab fees, the enzyme fees, the extra OR fees. So it isn't. Unfortunately, it isn't an easy procedure to fundraise for or self-pay for. So we really do depend upon that coverage, and the Medicare issue has been a problem, a real challenge for some patients.
So what is the youngest age this surgery has been done for children?
To my knowledge, 3 years old. The younger children are, so younger children, because they're smaller, physically smaller, are more difficult to perform some of the reconstructive aspects of the surgery, like putting the bile duct back together and the gut back together. And they are also more complicated for infusing islets in the liver, because a smaller liver is going to accept less tissue infused into it. So they actually have a higher risk for kind of early surgical complications, might have a few more bumps in the road. And in that respect are kind of challenging, but they have a really, really good long-term outcome. So the really young kind of 3 to 7 year olds have done historically quite well long-term.
Okay. And just a final couple here. Is there any effort to grow islet cells from stem cells that can be inserted into the liver and established prior to the
There is. Unfortunately, nothing that is probably too close to the clinic yet for patients with chronic pancreatitis. But there's a couple avenues that are being explored in that area. So there is a product that's being developed specifically for type 1 diabetes that would probably have application to this area later too. That is a embryonic stem cell derived line of islets for transplantation. That would have the potential disadvantage of maybe requiring anti-rejection medications to suppress the immune system, depending on how they were transplanted. But there are also other researchers who are working on taking your own cells, so say cells of the skin, reprogramming those cells back into stem cells, and then growing islets from those skin cells. So there is in theory, a way where people could be individually treated by kind of manufacturing their own cells, where they don't need any extra anti-rejection medications, and it's just like the auto-transplant. But I do think that's a number of years down the road, but that's an area that is actively being researched.
Okay. And just the final question here. You mentioned the negative impact of previous surgery on islet harvest amount. Does frequent prior ERCPs have an impact on islet transplant success?
We don't know. So from our institution, it looks like probably not in terms of the islet transplant and the diabetes part. We have seen some relationship with the number of ERCPs and pain relief, sort of more likely to have some chronic pain with a greater number of ERCPs. But that is actually probably pretty complicated, because it may be a marker of other things like having longer disease, or having something else that was also triggering abdominal pain, but you got pancreatitis from having kind of recurrent ERCPs, so it's sort of an iatrogenic pancreatitis. So it ends up being quite complicated. So probably not the ERCPs themselves, but maybe if they're associated with a kind of prolonged duration of disease, that might be harmful.
That's great. Well, first and foremost, thank you, Dr. Bellin and Amy, for putting together this presentation, being so open to answering all the questions. The fact that we still have 55 people on the phone and have gone over the time speaks volumes to the value that you're providing to this audience. So kudos and thank you for being such a wonderful resource. You can see on this last page, there are a number of ways to get in touch with us. We hope you will Again, join us in this effort and join our email list and share this webinar and other resources with friends and families, those that care for you and about you. And as always, if we did not get to your question today, we will be answering them either directly to you and/or in the Q&A document that we'll be posting on our website. Replays will be available in case you missed anything, and we're working on posting the charts as well for download in the near term. So with that, we will close it off. Again, thank you for your participation. Continue to watch us on Facebook, Instagram, Twitter, also on our website for future webinars. We thank you and wish you good health.